Hey guys, my name is Amy and I will be the leader and submitter for this week.
Hi, I'm Jen and I'll be the recorder this week.
Hi, my name is Mary and I'll be the facilitator this week.
Hi, I'm Joanne. I'm going to be the timekeeper.
Okay, so initially we're going to start off with the results of our individual assessment tool and then how it incorporates with our group findings. And we're going to follow up with the article that we reviewed, and then we will work on a proposed intervention and the plan for our DRJ group. So for my individual assessment tool, I found that some of the biggest things that I found was skin, elimination issues, and risk for falls. And I felt like as a group, how it compared is pretty similar. There's a lot of often and sometimes results on that. And what I found overall, I thought the biggest thing was skin breakdown, a high risk for skin breakdown, and then also nutritional deficiency, which kind of goes hand in hand with the skin breakdown, as well as with the elimination issues. So the articles that I reviewed were, one was for skin breakdown, and is twice daily skin moisturizing more effective than routine care in the prevention of skin tears in the elderly population? Excuse me. And this was by LeBlanc, Cazell, Martins, Forrest, Lelaine, and Lalongus. So I conducted this research because I thought that skin breakdown, it's a vital, important part of the health and well-being of any kind of aging adult. As we age, dating becomes more difficult, and it increases the probability of skin breakdown. I also think that there's a high component of maintaining self-care and a sense of dignity. The reduced mobility, incontinence, and the lack of hygiene practices can greatly affect the skin's integrity. This study evaluated the effectiveness of twice daily skin moisturizing, and if it was more effective than no moisturizing and preventing skin tears in the elderly population. What the results came out was that twice daily application of the moisturizer decreased the skin tears in the elderly population by 50%. And these studies completed a pre- and post-test design on the effectiveness of moisturizer, in which both showed a lower rate of skin tears when using the moisturizer. Incorporating an education program about skincare, followed by a 3-month trial of body wash and moisturizer, up to 3 times a day, decreased the incidence of skin tears. With our DRJ group, we have the older adult population, 65 and older, who are living at home. And I think the use of moisturizing is imperative to the skin integrity of the aging adult. The immobility and the incontinence greatly increases the risk of skin breakdown, and implementing the skin moisturizing will decrease the overall cost associated with pressure ulcers and wounds. In this research study that I found, they couldn't significantly say how much the cost was, but overall, the implementation of skin moisturizers twice a day would definitely decrease the overall pressure ulcer, wounds, long-term care for that. And the second article that I found, I just feel like a lot of the aging adults living alone have quite a bit of alone time, so they get quite depressed. Some of the assessment tool answers also showed some signs of depression. So an article that I found was kind of interesting. It was the effect of pet insects on psychosocial health of community-dwelling elderly people. So this one actually, the intervention group received 5 crickets in which they had to care for the entire study. And they did the geriatric depression scale, Beck anxiety inventory, and the mini mental state examination at the end of the study, as well as the completion. And the intervention with the crickets actually showed a decrease in levels in the scores in the GBS, the geriatric depression scale. I thought that was really interesting, but I think it just provides them an outlet to care for somebody and have kind of a sense of well-being and yeah.
That's interesting.
I was really searching more for like dog therapy, but the crickets came up and I was like, you know what, that's really interesting. I'm going to go with that one.
In the first article, was it a specific moisturizer that they used, or just any moisturizer?
Just any moisturizer. What they had is like a fragrance-free pH balance. They didn't say anything specific, like brand or anything. It was just a generalized, non-fragrant moisturizer.
Did they say any differences between like an emollient cream or a water-based moisturizer?
Nope, I did find one research article, but it was a systematic review.
Mm-hmm.
And that one, it was a protocol, and it showed that either using the emollients and the skin, like body wash, either the soap or the liquid, and it was more of saying that, yes, studies have shown that these, but again, it was just a protocol, so I couldn't really use that, but I think there's more research articles that could use those.
Interesting. So I found also a very high degree of similarity between the responses that we each got from our interviewed patient. I applied it to my mom, who I know her health issues because I take care of her when I'm home, but it was interesting some of her answers because even though I was her daughter, I don't think that she was giving me the whole answer unless I kind of probed, and I wouldn't have known to probe in those areas if I didn't already have a bigger picture of her health. So it's kind of interesting what she was willing to share and not. She definitely has a high risk of falls and nutrition issues, as well as some depression. I think that the self-care piece of it declines with feelings of depression and worthlessness and not having a purpose for getting out of bed every day. And I'm not sure that that is new for her, but it was interesting when we kind of got to like the elimination piece. While I knew she had some incontinence issues, she didn't really want to talk about it in the depth that even the questions got to. She didn't want to say frequently she couldn't make it to the bathroom, but I know that that was the case. So what I researched was the quality of life on older patients living by themselves, so the geriatric population. And I found a couple of articles. One was looking at a group of over 65 living independently alone, so not in like assisted living, and they couldn't have any significant health issues. So what they learned was, after 2 questionnaires and some education, specifically to quality of life, and they had the nurse interviewers read the questions and confirm understanding before they gave an answer, so that everyone got the same standard responses, I think. So there was a level of understanding across all of them, but that living alone was a risk factor for loneliness, but if you could give them social relationships and participations in some kind of hobby or group activity, that their quality of life scores increased. And then the highest risks of depressed individuals were those that had no caregivers that were assisting in any way, whether it be just checking on them, creating meals, or taking them to and from their appointments, never being married, and having a history or current diagnosis of depression. So they were really looking at the social interaction, or continuing the social interaction, even though they're living by themselves, to increase that quality of life perception in this small community of over 65 living alone adults, and it just happened to be in Italy. The other article I looked at was, again, living arrangements, social networks, health, mobility, and that effect of balance in older women. And pretty much it was the same thing. If they were less educated, less connected with their community, they had higher risks of feeling short of breath, lonely, depressed, and not really wanting to do anything. So I think it is applicable to our DHA scenario of an older adult living alone.
Okay, so I'll go next. I interviewed a 72-year-old female who works at the hospital. She volunteered to do my questionnaire. Again, I found very similarities between her answers and the answers given by the other older adults in our group. But she scored a little bit more higher on the sleep disturbance. She's, if she was ever told if she has snores, she said routinely, and then she had sometimes felt leg pain and cramps at night. So I researched an article about sleep disturbance and leg cramps, and I found one by Hawk and her colleagues that looked at leg cramps in people ages 60 years and older. And they reported that about half the people over 60 years of age experience nocturnal calf muscles at night. And so they also did some associative analysis where the people who reported more calf muscles at night also reported more snoring, more daytime somnolence, more just sleep problems in general. They also made the association that people who had less quality of sleep also had poor quality of life. And they explained that because of the quality of sleep that people were lacking. They also made the association that people who had calf muscles because of the lack of and poor quality of sleep, it was a predictor of depression, increased risk of dying that went beyond the association of age and gender, and other known medical burdens. They also identified that sleep disturbance was the strongest identifying predictor for future depression in the older adult population. They couldn't offer any ways to provide any interventions or preventions. They only said that maybe doing laboratory sleep studies would be best for this population, because there is no known treatment at this point to demonstrate consistency and effectiveness and safety for providing sleep or enhancing sleep related to leg cramps. So the only intervention that they could really provide is providing the sleep studies, just to make sure that there was no other known cause with the sleep disturbance, like snoring, like sleep apnea, or and just to make sure that it was related to this leg cramping. So I thought that it was interesting that they could make the link from leg pain, leg cramping to depression as an identifier of how it affects the older population.
Yeah, I think that's a really good article, because I can totally see if they're not sleeping well at night, then they're feeling fatigued during the day, and that's just going to, bring them down even more and increase the risk for depression.
Mm-hmm. And what's interesting is that she volunteered at the hospital about 3 days a week. Plus, she's very active in her community. She gets up and she's walking around, but she's still having these leg pains and issues with her sleep at night. And so
I know when I don't sleep well, I don't feel very happy.
Absolutely.
Okay, so is it my turn?
Yeah.
So for mine, I interviewed my neighbor. I noticed that she lived alone and she has visitors every weekend. I think it's her daughter, but she usually has like friends she plays bingo with. But other than that, she just lives by herself. So I interviewed her and I gave her the questionnaire. And what I found out is the questions that she answered often to were the first two, and also if she had a fall. The rest are there's mostly sometimes and never. So the first two was the do you accept life without regrets, and do you struggle feeling that your life is cohesive and meaningful? I realized that obviously they're older adults living by themselves, so they probably would experience a lot of depression in their lives. Like I noticed that in all your guys' articles and also the articles that I found, it mostly, and also with Jen's additional article about the skin moisture, a lot of them are about like depression. And so I feel like this is a good topic that we need to focus on, like with our older adult population especially. It's like something about that would talk about depression. So one of the articles that I found is, sorry, let me pull it up real quick. It's an article by Heish et al. It's physical activity and quality of life in older women with a history of depressive symptoms. I noticed that a lot of the articles are like geared towards women. I found some articles about like physical activity improving their quality of life, also geared towards women. I don't know why. Maybe it would be good to find like articles that would target both populations. So this one right here, they're trying to measure the HRQL, which is the health-related quality of life in older adult population. Physical activity is found to be positively associated with health-related quality of life. I think it's also because of, endorphins when you exercise and things like that. I feel like it definitely would help with their depression and their depressive symptoms. So it is not evident whether this association applies to older adults with poor mental health, any mental health, but this one definitely like applies for women with history of depressive symptoms. They had 555 participants, and for women in their 70s and 80s with a history of depressive symptoms, physical activity is positively associated with the health-related quality of life concurrently. And this study extends previous work by showing significant associations in older women with a history of depressive symptoms. So incorporating physical activity into depression management may improve the health-related quality of life. In the conclusion section, they did mention that, and it's kind of like pretty obvious because it mentioned that the health-related quality of life is increased with people who do the recommended exercise, which is greater than 150 minutes each week. They mentioned that it's better than no physical activity. And I'm like, well, duh. If the study is about like health related quality of life, it's improving by physical activity. Obviously, a lot of people who do not do any physical activity at all, that's worse than doing minimal physical activity. So they recommend that even just doing a minimal physical activity will definitely improve the health related quality of life. The second article that I found is also about physical activity and health perception and aging. So it mentions about does body mass and health and satisfaction about how you look at yourself, do they matter? The article. It says right here, although aging people could benefit from healthy diet and physical activity to maintain health and quality of life, further understandings of the diet and physical activity related mechanisms that may cause changes in health and quality of life perception are necessary. The purpose of the study was to investigate the effect of eating attitudes, body mass, and image satisfaction, and exercise dependence in the relationship between physical activity and health and quality of life perception in older individuals. So what they found was they actually did this study for all for middle age, young, old, and old. And what they found was at an older age, satisfactory body image is still definitely something that they look for or that they want, and that it improves their quality of life if they do more physical activity, if they eat better, and also if they have a better view of their body image. So I think we could also focus on, like, as an intervention for the older adult population, is aside from caregivers and aside from having actual people, it's also good to kind of look at your own body image. Like, go to a salon. I've seen like a lot of like older adults like do those kinds of things, like do their nails. Something that makes them feel good, not just having that physical companionship or having that physical interaction with other people, feeling lonely and depressed, but also just like feeling good. That concept of looking good, you feel good, and you do good type of thing.
Okay. Now I'm going to try to do a screen share. I inputted all of our data into an Excel file. I'm going to see if it'll show up here. And then maybe you guys can get a better picture of how everything kind of developed. So hold on here. There we go. There, can you see it?
Mm-hmm.
Yes.
Yeah, okay. So the life attitudes, that's where I took from the Erikson psychosocial stages. So where I got into the ego and versus despair, the ego integrity. So it looks like people said often, do you accept life without regrets? So 3 out of 4 people said that. With the skin integrity, the one that was, everybody was saying sometimes too, was they do inspect their bodies for physical changes and danger signs. And then only 3 said never to pressure ulcers. Let's see. And the one that I thought was really concerning with the problems eating. So if you look down here for the SPICES, those are the spices categories that we developed on our last Google Hangout. And then the questions that we developed underneath them are there. And then under the confusion category, we had about 7 people answered positively for that. And then sleep disturbance, we had the majority people answering above, sometimes and routinely. So that's a pretty significant problem for this population as well. Does that make sense?
How did 7 people answer if there's only 4 questionnaires?
So it wasn't really 7 people that answered. It was that 3 people said never to this question. 1 person said never to this one. And and there was a 7 questions were answered in this area here. Does that make sense?
Well, so number 10, specific to, I can't see, memorize or remembering instructions.
Mm-hmm.
If there were only 4 total questionnaires given, how do we have 7 offens? Or am I missing something?
What do you mean? So there's only 2 oftens.
Oh, it says, oh, I'm sorry.
Yeah.
In my view, it looks like 7.
Oh, really? Oh. Oh, shoot.
I was like, how 7? Okay, got it. Sorry. I'm so confused.
Hold on, let me see if I can move it up and down, because all I see in front of me is the screen. I don't see you guys. Hold on.
Because like when it says, do you make it to the bathroom on time? I can see that that's a 2. But the other ones look like 7s. But that's okay. Never mind. Skip it.
Okay. If I move it up and down like this, do you guys see the full screen or no?
Yeah, I can see it.
Can you? Okay. Let me see if I minimize this, if that's better. There you go. Can you see it better
now
now?
I can see it's a 2.
Okay.
I'm sorry.
Oh, so I was explaining all of this. You guys couldn't even see it. I'm sorry. There. Is that better or no?
Yeah.
Okay. So you see where the sleep disturbance, most of the people scored higher on the saying sometimes and routinely with there. And then 3 people said that they did notice weight loss sometimes. So they scored really high there.
I feel like all of the results kind of stem into like the depression factor. I think Joanne kind of talked about that.
Yeah, it all interrelates to, and I think it all points to when you do a convergence, even the literature says, all of these are related to depression, especially in the older population.
Yeah.
And especially with those living by themselves.
Yeah.
They're at higher risk.
Hold on, I'm going to close this out now.
Because I interviewed my mom, who's 65, and she's been living alone for, oh gosh, I don't know, 20 years. And she has a dog. She walks her dog about 25 times a day, but she doesn't have a big social circle. I'm pretty much it, which makes me terrified when I move on Friday, what's going to happen to her. But nutrition-wise, she's not fabulous. I mean, she's thin, but she doesn't eat very healthy, and she doesn't sleep well. She assesses her skin pretty well, but I think overall, I mean, she's pretty depressed.
Well, and my mom is 77, and she had a heart attack 3 years ago. and she hasn't really recovered very well. And I honestly think that when I travel and I'm not home during the week, she doesn't get out of the house. There's evidence of that when I get home. There's, no new groceries, no. So she does go to church, and she has a church community, but she doesn't have friends that she does things with. And I know that she is depressed, or at least has depressive symptoms. She doesn't eat well. She doesn't always take her meds. And that's concerning for me because she's severely hypertensive. So I'm afraid that she's going to have a stroke and nobody's going to know about it until I get home.
Sure.
On the weekend. So,
Sorry.
and she does have incontinence issues. So the other thing is she's incontinent and slips and falls. There's no one, during the week to check on her well-being. So it's a little frightening.
Yeah, absolutely.
And she had to retire because of her heart attack. And so I think that kind of fed into her depression. She doesn't really feel like she has reason to get out of bed or do anything.
Quite frightening.
So do you think we captured depression in our scale? Would that be one of the limitations, is that it's not comprehensive enough because we modified it so much that we're not capturing like the full details of what's going on with them?
Yeah, I think we could probably add more in, because the initial assessment tool, Mary, that you posted, and I had my mom do that just screamed depression left and right. But there was so many more specific depressive symptoms type questions, so it was a little bit easier to kind of hone in on that. So I'd say that's just one limitation of our tool.
Yeah.
Yeah, plus if you guys read the question, it's actually not asking too much about depression. It's kind of hinting at it. It's more like saying, do you struggle feeling that your life is cohesive and meaningful? It's more like a life satisfaction thing. How satisfied are you with your life? So maybe we can broaden that, make it a little bit more specific.
Yeah, there's not a lot of social questions that would kind of see where they are as far as engaging in the community and getting out and doing. Are they isolating themselves or are they socializing?
Correct. I agree with that. And I think that geriatric depression screening tool can give us some hints around other things that we should add.
Geriatric depressive screening tool.
It's a specific screening tool for patients over 65.
I've never worked with a geriatric population. I guess I've worked with some in the LTAC, but yeah, that's crazy. They have an actual assessment thing. Because for me, I thought for the geriatric population, it's dementia assessment, things like that. I never actually thought about depression assessment, because it's mostly for younger adults or something. That's where I noticed most of it. But yeah, definitely for the geriatric population, there's a lot of it too.
Yeah, well, I noticed on my unit that I work on, we do give patients a lot of, we put them back on their home medications, and we put them back on things like Celexa and Prozac and all these antidepressants.
Gotcha.
And I work in peds, so that's a completely different world for me.
Yeah. Yeah, and I noticed there's lots of pain meds usually for older adults, but not a lot of they only put them on Prozac it's not as a home ed. They're just using it because like they're in the hospital and they know that they're a lot more depressed when they're in the hospital, but they really don't have a diagnosis of like depression. But yeah.
And the sad thing is it's not even effective that quickly.
Mhm.
You need to be on it for a longer period of time.
Yeah.
So, and then I think that depending on what, sorry, Amy.
No, that's okay. Go ahead.
Depending on what era they're from, like my mom has an issue with being prescribed anti-anxiety or antidepressants because there's a stigma that goes along with that, and so she doesn't want to take them.
Mm-hmm. Absolutely. My mom is the same way.
Mm-hmm. My mom is too, actually. Yeah.
Do you feel that our assessment tool was long enough? Do you think like adding in a few more like depressive specific questions would help? I mean, we just kind of talked about that. Do you feel that there's any other areas that we could expand on?
I think that it's good for a first pass, but when we get those red flags, the always or the often, there should be some follow-up questions to get more in depth around those areas. If it's a never, we probably don't need to go any further.
I agree.
Mm-hmm.
So for interventions, so if we gave this questionnaire, and so what Jen was saying, anything that had an often or routine, we'd follow up with more in-depth questioning, doing like a nursing assessment on it.
Yeah.
And doing maybe following up with more screening,
Mm-hmm.
like a secondary prevention.
Yeah, that's good.
Mm-hmm.
Because then I think the individual plan within the intervention can be specific to what that patient is experiencing. Not necessarily in what we're going to do, because that's more in depth than we need to do, but in the big picture, I can see how if the patient's more at risk for falling or skin breakdown than depression, because they're very active and they have a social support system, then their intervention would look very different than someone who is completely isolated. So what do you guys think for our intervention? For that $20,000?
So what are they looking at specifically for like intervention? They want like actual tools? They want classes? They want like, or we can do anything we want? Like,
whatever we decide.
Okay. So we can like order, I don't know, like a movie theater or whatever, so they can enjoy watching movies. Yeah, something like that.
Well, if we're going down the depressive route, we could create, like geriatric outings that are pretty inexpensive, where we get people together to get out and, take a 2-mile walk if they can take a 2-mile walk. Get together for a knitting class or bingo, or like Joanne said, go to a salon and get your hair done, get your nails done, stuff to kind of get them out of the house so they're not sitting there alone.
Mm-hmm. So more like social activities type thing. So we pay for instructors or we pay for classes or something like that, so they don't have to buy, like, like an arts and crafts thing, so they don't have to buy their supplies, like we can provide those type of things.
Yeah.
Well, and what we would have to do is increase the questionnaire to target that quality of life piece,
Mm-hmm.
and then provide this intervention over, like, say, a 3 or 6 month period, whatever our $20,000 would pay for, and then reassess, did we make a difference in this group with their perceived quality of life?
Yes, definitely.
Yeah.
And I think that that's actually a really good one to target, because everything that we all researched was focused on depression, quality of life, and improving that. So we could incorporate all of those things, including physical activities, some nutrition education, self-perception, helping them feel better about themselves, and then helping them set up those social networks.
I think that's great.
I have a question. The $20,000, like if we're doing like some sort of like an intervention that we have to continually pay for, like, you know, pay for instructors and things like that, did it give us a specific time frame? Hey, we're giving you $20,000 every year or something like that?
Well, so what we have to do is create this plan,
Mm-hmm.
and then the board is going to decide which plan is the best use of that $20,000.
Mm-hmm.
So it has to be, you know, if we can show an increase in this community or population's quality of life, then they could probably get a grant or something to sustain it yearly.
Mm-hmm.
So that's really the basis of it.
Gotcha.
That's why there's a dollar amount associated with it.
It's like a trial, $20,000. Maybe we'll give you $1 million next time.
Exactly. Because it's going to be so awesome.
So do you want to kind of focus in on that, like activity meeting, classes, kind of?
I think so.
Yeah.
You know, like depressive behaviors.
You know, we can also utilize volunteers.
Yeah, totally.
So I remember when I was in college, my sister and I went to like an elderly home, and we painted like probably 10 ladies' nails.
Yep.
And they get to pick their nail polish and stuff. And so, you know, we can totally use volunteers for that. We don't have to like spend the entire like $20,000, especially like with an older adult. I mean, come on, like we all love the older adult population. So I feel like a lot of people would definitely love to volunteer.
Mm-hmm.
Well, and I think that's certainly part of the budget. The other thing is bringing in professionals, so physical therapists, occupational therapists that can help work with them, and paying for their services, in addition to dietitians, teaching them about nutrition and diet choices as we age. Maybe even someone that's specific around like yoga or things to help their sleep, because that puts them at risk for depression, those things. And then how are we going to advertise this? So all of that costs money. And where are we going to hold these things, and who's going to pay for the gas? So all of that goes into the budget.
That's true. Because in my head, this is like a senior living community. That's what I was thinking about. But then I realized, well, not all the older adults live in you know, senior living facilities. Like my neighbor right here, just across the hall. So,
and that's our scenario, right? A
mhm.
geriatric person living alone.
Yeah.
Well, and I know, like in Phoenix, we have 12,055 and up only communities. So that's kind of a community that you could target, and most of them have community centers, and that's where we could hold these educational services or nail done services, you know, that kind of stuff, where, you know, you could possibly just not have to spend money on renting out a facility, but one of the residents that live there could just rent it out for the night and use it there.
Yeah.
We can also tap into nursing students and CNA students for
Absolutely.
your volunteers.
Yeah. That'd be great.
Well, we can actually make it part of the nursing students' education.
Yeah, go to the colleges.
Mm-hmm.
You know what? We did that. Oh, that's funny. No, I wasn't. So in my group, of our populations group, that's our last class ever of the semester. I did a different population. I just went outpatient. We took blood pressures and stuff like that. But there's actually like a manor full of like the older adult. I think it was like you have to be 60 years old to live there. But they would like start bingo and stuff like that. And so our the people in our group, I mean, they're other nursing students. They did the bingo every week, and they took them on walks and stuff. And that's part of our credits, like a 4-credit-hour class. So I think it's cool.
Yeah. I think we have lots of avenues to pull from where we don't have to spend money, and we can show them that it won't cost that much money overall.
Yeah. And
then it makes it more
scenario
sustainable.
right now. What? Oh, and I'm looking at the scenario right now. It says it just has to be a small health promotion and risk reduction intervention, so it doesn't have to be anything that elaborate.
So just a senior community, like a specific community thing we can target.
Yeah.
Okay. Do you feel like we came up with the intervention and plan?
No.
I think so.
All right. Well, shall we stop broadcasting, or we still need to discuss? Sorry.
Well, I'll send everyone that geriatric depression screening tool
Yeah.
because we have it in our content, so I have access to it.
Okay.
And we can figure out how we want to fix the, I don't want to say fix, there's nothing wrong with it. Enhance our questionnaire so that we can actually use it as part of our intervention to target those patients that are at risk for or currently experiencing depressive symptoms, and then make them part of our intervention group. And then we would give them the same questionnaire after our 6-month period of providing these services.
Yeah, we can definitely do that.
Even if you just put like an asterisk next to those two like depressive questions that if answered,
If yes,
never
then.
feels fulfilled. Yeah, if yes, then da-da-da-da-da. Ask the follow-up question.
Yes.
Cool.
Okay, I think we're good.
We good?
All right. Yep. We're definitely good.
Okay, I'm going to stop broadcasting.
Okay.